Thank you so much for joining us. I'm going to go ahead and get started. So we're so excited to welcome you. My name is Jacinta Kapungu, and I serve as Gender Community of Practice Co-Champion. This is a webinar entitled Breaking Boundaries, the Intersection of Gender Inclusion and Mental Health. I'm here with my colleagues, Candice Chirwa, who is the Community Practice Co-Champion and Youth Advisor, and Samantha Nyakundi, who's from the Youth Advisory Group. Next slide. I just want to give a little housekeeping before we start. Please mute yourself when not speaking and keep your cameras off to help manage bandwidths for everyone. We encourage the audience to post questions in the chat at any time. We'll be taking questions along the way. Turn on English closed caption with the double C button at the bottom of your screen. And this meeting is going to be recorded, and the recording and slides will be available later at youthpower.org. And then if you have any technical issues, please contact Catherine in the private message, or you can also email her. Now, for those who are continuing to join, please feel free to introduce yourself in the chat. In terms of our agenda, I'll first give you an overview of the Gender Community of Practice. We'll have a discussion on the intersection of gender inclusion and mental health. We felt that based on COP members' requests, they wanted to have more information on how to help girls and women make informed decisions about their health. And given the state of our world, given humanitarian crisis, violent conflict, climate change, we thought that this was something that was cross-cutting across the world that is important. So we're here today also to introduce you to a product that has been developed that will help program implementers address mental health and gender. It's the Mental Health and Psychosocial Support Toolkit. And then we'll have the Friendship Bench talk about their community-based mental health program in Zimbabwe, and then remind you of some upcoming events. Next slide. To give you an overview of the Gender COP, our purpose is really to promote dialogue. If everyone can put their everything on mute, thank you so much. So the aim of the Gender COP is really to promote dialogue that is inclusive, contextually relevant, and localized. We really want to have engaging, interactive, and insightful discussions which promote cross-cultural learning. So one of what we've learned is that it's important for us to provide practical strategies which you can use in your work, which will improve gender intentional work. Next slide. So if you're interested in joining the COP, you can please register at www.youthpower.org. And it's an opportunity to connect with others through the COP pages. And you can connect with organizations. We also have a discussion group, and we also send information on future events. We also send information on the last Monday of each month, and we call it Mindful Wishful Mondays. And that's where we provide information on events, job opportunities, and future webinars. So please feel free to sign up. Next slide. So today, we are blessed to have two speakers with us. We have Nicole Shehadeh. She's the Senior Specialist at Making Sense Internationalists in Mental Health and Inclusion, and Mary Munetsi, who serves as the Youth Friendship Bench Implementation Manager at Friendship Bench Zimbabwe. And I'll introduce them more later. Next slide. Okay, so our first speaker, Nicole Shehadeh. She has over 8 years of experience working in development and emergency settings, specifically on social and human protection, development, and diversity and inclusion work. At Making Sense, where she serves as the Senior Specialist of Mental Health and Inclusion, Nicola plays an active role in shaping inclusive and equitable global mental health and diversity and inclusion policies through programmatic interventions and institutional approaches. I'll hand it off to Nicole, and feel free as she presents to put questions in the chat. Pass it off to Nicola.
Thank you, Jacinta, for introducing us and for organizing this, all of you. I want to thank the COP team. So yes, nice to be here. I'm gonna be walking us through, like Jessina said, first and foremost, on the importance of intersectional work between gender and mental health and why it's important. And please feel free to, if you have any questions, just put them in the chat. I'll answer as I'll go along. So as you can see in the first slide, this picture I like because it helps us put into context or into figures or image in our mind visually what does intersection mean. We live in big societies, and in these big societies or environments we have smaller social groups that intersect among each other, sometimes overlap in interests, sometimes diverge in interests. So it's important to keep in mind while we're working with groups on the ground that they have differing needs, they have differing lived experiences, they have differing identities, they have differing interests, or sometimes similar interests. Next slide, please. I want us to, if you can, maybe scan the QR code to answer this question, or you can go to slido.com and put the code there. I want us to try to answer the question for the next 1 or 2 minutes to why do you think it is important to include gender considerations in mental health? There's no right or wrong answer, but if we want to talk about, if you want to think about why it's important to think about gender-related issues while implementing mental health services. Risk of mental health increases by gender. That's definitely one of the things that we're going to talk about in our next slide. Gender norms will have negative impacts on mental health. 100% yes. Stigma around mental health can be gendered, crazy woman. That's also something we talk about, especially with how we pathologize femininity and feminine experiences. Like we say crazy woman, we talk about hysteria and histrionic disorders. One of the biggest determinants of mental health. As part of the whole person, gender considerations can be a crucial part of one's experience. Increased suicide of youth, because it is generally a taboo on the African continent to speak on mental health. Because we are not a homogeneous group, exactly what we're trying to say. Exactly. Societal expectations and norms can impact how we perceive ourselves, mental health issues ourselves, how we express mental health issues and needs, and how we seek help. So help-seeking behavior, it's affected by gender norms as well. 100% regarding the point on men feeling the need to suppress their emotions. Okay, for the sake of time, I'll have us move on, but I'm just gonna say that you can all present on my behalf because all of these answers really are in line with what we're trying to explain, why gender consideration are really important in mental health. It can definitely lead to more equitable mental health services. So how you can see in the slides, you're gonna receive these slides later on by the via email, but I'm gonna focus on on the effects of gender discrimination or gender norms on mental health specifically and human development. What we see is that mental health can affect um, what we see is that gender norms can affect mental health, the mental health of the people differently. So, for example, women, female identifying, cis women primarily, and female identifying individuals might record higher rates of anxiety, depression, self-esteem and body image related issues. We have, and we can see in the slides here, we layered the levels of gender norms. Gender norms and stereotypes can affect social and cultural norms, the broader lens that can affect gender and behavior. And then more closer to us, we have gender norms impacting mental health. collectively and individually, and specifically based on differing identities or intersectional identities, it affects marginalized groups differently. So on the wider scope, mental health can dictate toxic masculinity behavior, misogyny, trans misogyny, and different types of queer phobia. On the mental health aspect and impact on well-being, mental health can lead to gender norms, can lead to, are correlated more with eating
Hola, buenos
disorders,
días.
um, are correlated to more eating disorders, body image issues, anxiety, depression. Sometimes we see that postpartum depression is not treated equitably or not responded to adequately. We also see that witnessing or being exposed to violence, whether an intimate partner violence or gender-based violence, mental health concerns might increase, very well increase. Help-seeking behavior for mental health needs might increase. Sometimes we feel shame or embarrassment to explain what we're feeling. Sometimes when experiences of pain or anxiety or trying to explain symptoms to maybe healthcare professionals or mental health might be um, dumbed down, if you want, or um, basically not taken into consideration or seriously. So, for example, we can say that maybe they're seeking attention instead of actually listening to the patient. We might sometimes say that this is just a histrionic behavior, which is historically what most women were labeled as when they seeked help. We also see that Black women are at a higher risk of easily avoidable pregnancy complication, and so on. Next slide, please. Gender-based discrimination, in particular in mental health and healthcare, we see that it affects access and bias. So if we want to talk about access and bias, not everyone has equal access to healthcare services or mental health care services. We can also see that in medical practices and psychological practices, there are deeply rooted biases in treatment. So like I said before, sometimes we label specific symptoms that are very real as psychosomatic or histrionic. Sometimes there is psychosomatic symptoms. Sometimes there are real symptoms that we should take into consideration and take seriously and listen to the patient. Sometimes we see that trans women are not able to receive the adequate help they need based on transphobia and transmisogyny. Sometimes we see that Black women, as I have explained, have less access to adequate healthcare or mental health services. We see misdiagnosis and lack of trust in workers' ability. What that means is that sometimes we see that women healthcare workers are less trusted in their abilities and skills. We also see that discrimination and underrepresentation in research in mental health and healthcare. So the predominant group that is recruited for research purposes are heteronormative males. We have underrepresentation in terms of LGBTQI plus groups, in terms of women groups, including different racial groups. We also see we also see misogynoir in practices. Misogynoir is a coin term. I can send you the resource for the sociologist, but the term is the merge between misogyny and noir, meaning Black. So misogyny specifically targeted towards Black women. So racism and the intersection of sexism and racism. We also see gender-based discrimination in leading to stigmatization and cultural misogyny. So we have stigma and stereotypes in media and tropes, negative tropes on women, on Black women, on trans women in media, on indigenous women as well, differently. We see sometimes that the views on trauma and mental health issues are very narrow, only focusing on experiences, white experiences or white cishet experiences. So for example, feminist theories has expanded the understanding of trauma. So instead of only individual trauma, we talk about collective trauma, historical trauma, um, and insidious trauma that I will talk more about later. Next slide, please. So based on what we talked so far, making the case why gender, what happens in healthcare and mental health, the impact of gender discrimination and gender norms on mental health and well-being, we focus on the importance of inclusion in mental health. Inclusion means that we actively try to fight the stereotypes out there and the exclusionary practices that usually and historically have excluded women, LGBTI groups from the conversation around mental health, from adequate treatments and research on mental health and healthcare. For mental health, for example, what does inclusion mean? Inclusion basically steers away from mainstream Western practices. It focuses on localization, contextualization, two very big important premises that also USAID works on. It actively seeks to fight biases and actively seeks to assess where the biases come from and how we can fight them. It adopts a do no harm approach and a rights-based approach, so a human-centered approach. It really relies on collaboration and meaningful engagement from local groups, local marginalized groups, local women groups, local community stakeholders, and key people. For sustainability and for continuity and for strengthening capacities of communities. It does not view mental health as a one-size-fits-all, and it does not view mental health as something that we, as if I'm coming with the knowledge, I don't view my knowledge as better than local communities. I understand that local communities have their own knowledge and have their own practices that worked. So we seek to merge these two together, maybe resources that we can provide and local mental health practices. And it views humans as assets. So it views humans as autonomous, independent agents that can make their own decisions and they can know what's best for them. Next slide, please. One toolkit that basically focuses on inclusion in mental health as the Mental Health and Psychosocial Support Toolkit. We're going to send you the links after. So basically what we see happening or what the aim of inclusion and what this toolkit helps in is that, first of all, it takes this viewing humans as asset approach, which is a positive youth development lens that views youth and humans as assets. So they have something to give to society, to themselves, to their community. They have the skills already, they have the agency, we work with that. And also it focuses on a rights-based approach. So basically merging human rights, understanding that humans live in systems and how we can work with them based on that. The toolkit provides you guidelines on programmatic implementation. So how you can design the program, how you can implement the program, what recruitment aspects you need to focus on, what trainings you need to focus on, and how can you monitor such programs. Basically, it provides you with tools to basically think about how you fight stereotypes, how to actively reduce stigma, how you think about accessibility issues. So for people whose services are less accessible for, so basically maybe vulnerable groups, children, youth, but also how you can increase accessibility for people with living with disabilities, increases sense of belonging, helps you. So on the longer run, inclusion can help once you start focusing on increasing accessibility, reducing stigma, and creating this space that is focused on a rights-based approach and a do no harm approach. On the longer run, you start focusing on increasing sense of belonging for the community and for the service users. And on the longer run, you can also help prevent comorbid disorders or complications that come from untreated mental health needs. So it increases access to treatment otherwise unavailable. Overall, a wider scope, if you want to think of this as on a national or a governmental level or like a societal level, overall and over time, what does this do is it decreases the overall burden of mental health. There is a cost to mental health. So, for example, unaddressed mental health needs um, sometimes lead to leaving the workplace, protection issues, homelessness, experiencing homelessness, other mental health or healthcare complications. So addressing that early on and being inclusive can help decrease this burden of complication. Next slide, please. So while the toolkit provides you with programmatic guidelines that you can adopt in your own organization or programs or activities, if you're not a mental health professional, you can also adopt a mental health approach or lens to your work. You don't need to be a psychologist or social worker or counselor. What you need to do is just understand the complexity of being human in a system, existing in a system, in a society, the understanding how each one of us experience these systems. One way we advocate that people who work in different aspects and different activities, not necessarily in mental health directly, can adopt is a trauma-informed approach. Trauma-informed approach, like a feminist trauma theory, um, definitely sharing these resources. Will liaise with Chisina and the COP group and see, and they have the resources and they can send them to you definitely. So yes, a trauma-informed approach builds it really similar to a feminist and queer theory on trauma. Basically says that trauma is not the burden of the person. The traditional mental health approaches in treating trauma are based on post-traumatic stress disorder treatment, which stems from the American Vietnam War. Um, what does that mean is that the research that has been done focused on military veterans, which predominantly were cishet males. What that means is that any other experience that we might feel, that those of us who are women, cis women, trans women, Black women, indigenous women, LGBTI, broader queer people, um, all other groups. So every other group in the society we live in or in the communities we live in, the treatment of PTSD was not really a size fits all to everyone. So what these theories or approaches say is like, hold on, there is more to traumatic experiences and lived experiences. There are individual traumas, yes, but there are continuous and complex traumas, which means that sometimes you might receive different types of traumatizing incidents, like maybe surviving war, living in insecurities, living in experiencing poverty or homelessness, and experiencing violence, whether physical or emotional violence or harassment or discrimination. And we can see that throughout. So we can see, for example, intergeneration and historical trauma. One example is racism in the US and slavery. Another example, for example, is civil wars or genocides. Those are examples of collective, historical trauma, whether continuous, still ongoing now, or that happened, but we see their remnants and legacies inherited by generations to come, by policies around us, and laws around us, and practices and norms. Another form of trauma is the insidious type of trauma that, for example, uh, uh, underrepresented gender groups and women face. One example is if I ask women in the group here, if you want to jog, if you like to jog and you want to jog, at night, would you do it? Yes or no? What would you think of? Most of you would tell me, hey, I might not listen to music because it might not be safe. I might run with someone. I might share my location with someone just to stay safe. Cishet men usually do not think of all of these because why? It's not because they always feel safe, because the system they live in is more violent towards specific groups of people, in this case, women, as opposed to cishet males, depending on the system you live in. That experience in itself, the risk of threat of harm is enough for you to experience similar symptoms of trauma. And this is what we focus on. This is a long way to tell you that we never know what the other is experiencing. So best to adopt a mental health informed approach or a trauma informed approach that takes into consideration these lived experiences. So how can I create, this is what I need to think of, a safe and psychologically safe environment. I want to focus on safety. I want to focus on peer-to-peer support. I want to focus on agency. So create space where service users can feel more independent, more responsible, that they can feel they can take their own decisions. I want to create an environment where I can offer choice and consent, privacy, confidentiality, and security. So this physical space where they're at, is the group gender diverse, all of that. It understands that mental health concerns are not only related to trauma. You have anxiety, you have stress, you have depression. Sometimes you have just self-esteem issues or other things. We don't know. Simply, we don't know all the lived experiences. It considers the diverse lived experiences, and it is aware that not everything is visible for us, or not everything is seen or understood. And there's no need to understand all of it. We just need to create the safe and psychologically safe space. It adopts a human-centered approach, focuses on do no harm, and a human-centered and rights-based approach. Next slide, please. Purpose of integrating mental health and psychosocial support into gender-based violence. So the toolkit that we're gonna share with you, basically sometimes you're gonna ask, we explain why it's important. What it does is it does not only focus on how you can integrate mental health services and gender-based violence protection services and programs, but also why it's important. So basically it protects and promotes psychosocial well-being through NJBV protection programming. It helps you think about these safe spaces, how you need to create them, but also from a psychological perspective, mental health perspective. It focuses on the overall well-being, so the recovery process, the healing process, but also sustainable next steps. And it really focuses on a survivor-centered approach. So instead of us knowing what needs to be done, us asking and creating the space for choice and agency and autonomy for survivors to come forward and decide what they need to do, how they need to move forward. So it has this best interest at heart, and it has this do no harm lens at heart. Friendship Bench is a great example on how they focus on integrating these approaches together, integrating a do no harm or like a human-centered approach into that, but also a great example, Mary will explain more during her presentation, a great example of how peer-to-peer works. Next slide, please. In the toolkit, you'll also see illustrative activities based on the positive youth development domain. So the positive youth development basically says that you'd have assets, they have skills, they have agency, how we can create in the domains, how you can focus on developing their assets, how you can focus on creating an enabling and safe environment, and how you can focus on creating this space for choice and agency and independence. So next slide, please. One approach we adopt to think about how we integrate mental health services is the interagency standing committee guidelines or systems. You have on the broader view, you have the broader community considerations. So for example, awareness raising. And then you have more targeted activities for like family support or system support, which basically can include parental counseling, parental support, parental guidance, service provision for emotional support groups or trainings for community workers, livelihood programming, stuff like that. Then you have more focused and specialized support. Basically, you can have case management here, individual case management, counseling, individual counseling for like plans, protection plans for people, and some, and at the the last point, it's not the least important, they all complete each other, is the more specialized services. So if people required medication, required more targeted treatment and help from a psychiatrist, psychological diagnosis, all of that, that's or additional services, that's the last point of the pyramid. As you can see, you can think of to yourself that your activity can maybe cover one or two or all of them, or maybe one of the aspects, and it's fine. And as you can also see is that all of the aspects should exist to complete each other. Next slide, please. Those are some series of recommendations that we ask you to think of while you're thinking of programming. Basically, everything that I said about trust and safety, tailoring support, so human-centered approach, so what they need, not what you know, and how you can create sustainable programs with the community-based and localized partnerships, and how you can monitor your improvement or monitor your services. What type of research or monitoring tools you need to implement in partnership with local communities and stakeholders. Thank you. Thank you. That's, I think, the last slide. Jessina, back to you.
Thank you so much, Nicola, for reminding us of the importance of adopting a human-centered and gender-inclusive approach, which helps understand mental health concerns and how it intersects with our lived experience. Very substantive presentation, and we will be sure to send the resources. And I encourage everyone to review the resources and reflect how you can be more intentional in addressing the intersection of gender and mental health. It really intersects with violence, education, economic empowerment. And so it's important for us, especially in today's world, to be more intentional in addressing it. I'd like to introduce the next speaker. So Mary Munetsi is an implementation manager for the Youth Friendship Bench and holds a bachelor's degree in sociology and special honors degree in psychology. She's an individual who is passionate about youth mental health and seeks to break down the stigma surrounding mental health through psychoeducation and raising awareness on mental health and to provide support to those facing mental health challenges. I'll pass it off to Mary.
Thank you so much, Christina. Hello, everyone. It's good to see you and welcome. So like Christina has mentioned, I'll be focusing on the Friendship Bench model just to share with you how we have been implementing as an organization. So just to share with you a brief background of how Friendship Bench came about or who we are as Friendship Bench. Basically, Friendship Bench is a private voluntary organization that was founded by Professor Dickson Chibanda, who happens to be one of the few psychiatrists that we have here in Zimbabwe. This initiative came about after the government after a government mandated settlement or cleanup campaign, which here they refer to as Mramba China, that is in the local language that is Shona we have. And after this happened, a lot of people were affected. Homes were destroyed and families were displaced, and people were shaken, resulting in depression as a mental health condition. So as a result, Professor Dickson Chibanda had to work with grandmothers who were trained to just sit down on a wooden park bench and provide problem-solving therapy so that they reduce or help people who were going through depression, which we refer to as kufungisisa in Shona. Kufungisisa really doesn't mean depression, but it just means thinking deeply, which closely relates to depression in Shona. So when the grandmothers were trained, a randomized control trial was conducted with the initial 14 grandmothers, that is in Bare. So these grandmothers that I'm referring to, they are basically community healthcare workers, or Mbuya Hutanos. They're just the bridge between the clinic or the mental health sector and the community. Hence, they do report any health issues that are within the community to the clinic or to a health facility, or they then again give feedback to the community on different health issues that the health facilities would want to communicate to the community. So basically, these are the grandmothers, and I guess you can see one of them in the picture. We can move to the next slide. Okay, so basically, I'll share on how the friendship bench model works. To start with, we are informed by research, right? That is the first port of entry to the work that we do as an organization. Like I mentioned earlier, a randomized clinical trial was conducted just to see the effectiveness of problem-solving therapy, having the grandmothers being the major or the main delivering agents. Was it going to be effective in helping people get out of depression or in reducing depression in communities in Zimbabwe? So as the friendship bench, we're informed by research, and we train or we equip grandmothers and youth bodies to provide therapy to people within their local communities. So youth bodies, these are just youths, peers who just provide mental, who provide problem-solving therapy to other youths as well. Then that's the second component. Third component to our model is we make use of the local language, which the client is free to, have a use in having the conversation or use when having the session. So you realize like the client is empowered to choose which language they want to use. So locally, we have got three main languages: English, Shona, and Ndebele. And all of our tools that we use or the sessions that are provided, they're provided using the local language. That is the third component within our model as friendship bench. Then fourthly, we have the therapy being provided on a wooden park bench, and it will be actually labeled a friendship bench. The main reason why we use a wooden park bench that will just be outside in a discrete area is just to reduce the to reduce the stigma that is around mental health. I think we all know, or we all are aware that locally here in Africa or in Zimbabwe, mental health is an issue that is mostly surrounded by stigma around it. People really haven't really accepted that mental health is really an issue. So we have our sessions taking place on a wooden park bench. So this can either be in the community or at council clinics in the communities that our grandmothers and our youth bodies are found in. Then fifth, we have the problem-solving therapy being used, right? And when we use problem-solving therapy, which is basically one of the cognitive behavioral therapies that we have. So problem-solving therapy, when we use it as an organization or when our delivering agents are providing sessions to clients or to people within their local communities, they will be basing them on three main pillars, right? So to start off with is just to open the mind of the client, just to help them see that, of course, they're going through depression. Of course, they are going through a lot of problems or they're facing a lot of challenges, but that doesn't mean it is the end of the world. There is still need for them to, find solutions out there. Of course, this just may be a phase that they're going through depression, but it's something that they can deal with. So firstly, we open the mind of the client just to be able to accept that depression is a mental health issue or a mental health condition that they can work on and get better. Then secondly, we have uplifting our clients. So you realize like with depression, one might really feel sad, right? And they feel down, if one can say. So our main agenda as an organization or the main agenda of the approach is to just uplift our clients as well as empower them. So you realize with depression, one might feel down and they feel there's nowhere to go. They really can't think outside the box. So we, as the sessions will be providing through problem-solving therapy, there is an empowerment that comes with the session. We have our clients expressing solutions that they feel can help them solve the challenge or the problems that they are facing, or that can help them get out of depression. So our grandmothers and youth bodies are equipped on how to empower these clients, as well as strengthen whatever solutions that our clients have tried. Because our main belief is the client is the one who really knows what they're going through, right? And then secondly, they know the resources that they have readily available so that they can just, they can work on the challenge, on the problem that they are facing. So instead of just advice giving, right, we train our grandmothers and our youth buddies to empower and strengthen the readily available solutions for our clients. Then lastly, as part of the friendship bench model, we have continued support. So these sessions that I've been talking around taking place on a wooden park bench, there will be one-on-one sessions, right? Whereby it's just basically the grandmother and the client, or the youth friendship bench buddy and the client. So there is continued support, which is through psychosocial support. These we refer to them as seko kubatana tose, which basically translates to just a seko where we hold hands together. So we expect our clients to actually form a group or a psychosocial support group so that they work around depression. I think we're all aware that depression comes with after one has faced a challenge, or after one is going through something. It's something that can just come and go. Whereas one can just we can't really say that one can live without depression. It's something that one can experience. So we expect our clients to also share solutions and also support each other, since they all would have gone through depression. So for the psychosocial support groups, these tend to differ with context or with the group. You realize, like for adults, mainly they'll be into income generating projects, because these will be informed by the challenges that they will be facing, right? Which might really want to work around, which might really require them to work around getting money or have income generating projects. Whereas for the youths, these can differ, because you realize like some youths will be struggling in connecting with others or in socializing. And for their CKT groups, basically there'll be more about interaction, which I'll then share with you as we go. Thank you. Next slide. Okay. So basically, moving from the model, now this is how our intervention or our model came about. As an organization, we are also into implementation. So for us to implement, these are some of the stages that we do follow through. So I'll just share with you, or I'll just go about these different stages. Please feel free to ask any questions in the chat so that I address as we go. So for the intervention design, basically this is our these are the steps that we followed through. So to start off with, there is the needs assessment, right? As an organization, we first assess the need to have a friendship bench, or the need to have the friendship bench model being implemented. So you realize, like, I'll give an example of how we came about with the youth friendship bench, right? So when Friendship Bench initially started, I mentioned there were the grandmothers providing therapy, right, to other community, to their communities, right? So we realized, as an organization, we then realized that there was a very little flow in terms of the youths that were coming to access the service, the Friendship Bench services in terms of depression. And yet we say that depression actually affects everyone. It really doesn't segregate, like, okay, this is an adult, will affect only adults. So you realize, having us realizing that depression affects everyone, we then wanted to see why then were the youths not really forthcoming to the service? Why is it we were just having very little numbers of youths accessing our friendship bench? So we conducted a needs assessment. Is there a need for us to have like a youth friendship bench, or is there need in terms of depression affecting youths? And yes, we realized that it was there. So we did conduct a needs assessment, right? Through quantitative and qualitative conduction of focus group discussions. So we did have focus group discussions with grandmothers, them sharing their concerns, or also sharing what is it that they really saw being the main effect of youths not coming to the friendship bench, right? And again, focus group discussions were conducted with the youths themselves. Then we moved on to literature review. We are also informed by the literature that already exists, be it locally or globally. So we also tend to research on how then other youths accessing mental health services, be it in other countries or locally. We also did a literature review on other organizations that are within Zimbabwe, within our context, and just to see how they were having the youths coming to access the services, right? And we also identify evidence-based interventions that really aligns with the population needs. And in this case, our population were basically the youth. Then there is development and adaptation, right? We conduct theory of change workshops. And in these workshops, they are mainly informed by, we are mainly informed by our stakeholders. These are the people who really work with the youth. We talk of the Ministry of Health itself being our biggest stakeholder, just to give us highlights and ways in which we can go about having youths coming through. We also have our grandmothers, those who also have been just having the intervention going on, so that we learn from them. They also share with us how best we can go about it. Then again, we have the youths, which is our target population in this case. So we are also informed by the target population, right? Our stakeholders, as well as our delivering agents, so that we come up with an integrated solution to addressing mental health challenges or the mental health challenge that we would want to address. Then the fourth stage will be pilot testing. After we have had a theory of change and development of the intervention, we first piloted. And in our case, for Youth Friendship Bench, it was pilot tested in Kuwadzana, which is also one of the high density suburbs that we have here in Zimbabwe. So the pilot testing just would be there to help us in order for us to just see the feasibility and acceptability of the study. So for our pilot testing, we then had Youth Friendship Bench buddies who were then providing the therapy. So you realize, like, for us, we had grandmothers providing therapy to youths, and then the other group or the other side, we had the youths providing sessions to other youths as well. So moving on, we have the next stage, which was just a clinical trial, which I was just talking about, whereby we had youth buddies providing sessions and also grandmothers providing sessions. And these two would run like at the same time, so that we have results, or we see the effectiveness of having an individual providing sessions to another peer as compared to a grandmother. Then after the clinical trial, we then have a scale up. And it is my honor to inform you that what we realized as an organization is that youths would feel free having a session with another youth, because here, context-wise, you realize that it's actually considered a taboo having some conversations like discussing sexuality or issues about a boyfriend or whoever you're having a relationship with, someone who is the same age as your mother. So you realize, like, these are the issues that some youths would feel comfortable sharing with other youths. And this led to having a youth friendship bench, which operates the same way as the classic friendship bench, where we have grandmothers. Next slide. Okay, so this is basically how the youth friendship bench works. I'm happy that someone mentioned when Nicola was presenting that we are really affected by the high rise of numbers of youths who are committing suicide, and who in 2021 actually had it that 7 out of 10 people in the population between 10 to 19 years have a mental health disorder. And one of the top 4 mental health disorders is depression. So for Youth Friendship Bench, we have had sessions with different youths, and some of the causes of depression amongst young people locally with regards to unemployment. We talk of poverty, peer pressure is one of them, and this really encompasses a lot of things, where we have got fear of missing out. For more, we also have issues around body image. Then also family conflicts have been another cause of depression amongst young people, relationship issues. So in trying to address these challenges, we have peer-to-peer counseling, whereby there is a youth who is supporting another youth. And with reference to gender as well, we try to accommodate all groups, right? Whereas we have got males providing sessions as well as females. Then we also conduct mobilizations as Youth Friendship Bench, where basically it's just like awareness raising around mental health issues. And we do conduct them over social media platforms. We talk of WhatsApp and Instagram. And also we conduct physical community. We also conduct physical awareness campaigns through community outreaches, and also we go to tertiary institutions where we feel like those are some of the institutions that are youth dominated. Then, like I mentioned earlier, before again, cognitive behavioral therapy is the approach that we use, and we also use problem-solving therapy. But again, we realize that youth are mostly active on online platforms. Hence, there's an integration of a physical session whereby there is problem-solving therapy being provided physically, as well as online, whereby the youths mostly they're active on WhatsApp, and we use the WhatsApp platform to provide problem-solving therapy. Then, lastly, we have second from last, we've got psychosocial support, CKT, which I mentioned earlier, and we also use the online platform for networking as well as discussions amongst youths. Then also for physical, these then are informed with the group that we will be working with. We realize like for our youth, we've got two groups. We've got those who are still going to school or who are still high school goers. And we also have youths who have completed their degrees. Because as Youth Friendship Bench, we work with people between the ages of 15 to 25 years of age. So you realize in terms of psychosocial support groups, some might feel they need to work around income generating projects, and others just feel like, you know what, we just need to socialize. And this basically is the group of the high school goers. Then lastly, we have supervision and support for our peer counselors, those who provide sessions or who provide support to other youths. We do supervise their work, and also we support them in terms of how they provide sessions, as well as just for them to just have a platform where they just let out, and also they just feel they can share experiences amongst themselves. Next slide, please. So basically, these are the buckets that we work around as Youth Friendship Bench. Sensitization basically is just a stakeholder engagement, whereby we try to engage different stakeholders in trying to reach out to our youths. As our mission, as our vision is to have a friendship bench within a walking distance, we hope to have friendship bench to reach out to different institutions where youth are also there. Mobilization, I have also explained that is basically awareness raising. Then we also have a bucket of training where we train or equip our peer counselors with basic counseling skills, as well as problem-solving therapy. Then we have got problem-solving therapy, PST, being provided. And I've mentioned supervision. We supervise our bodies, or we supervise our peer-to-peer counselors. Then there's data capturing. We are, as Friendship Bench, we are informed by our data. Remember, I mentioned research, and this research is informed by the data that we capture. So after every session, one is expected to capture the information of the client within our database. And basically, these are demographics and the challenges that the youths are facing as well. Then we have a last bucket that is reporting and feedback. We report to our stakeholders as well as the Friendship Bench team. Like I mentioned, we have the team that works with grandmothers and the team that works with the youth, so that we also draw lessons from each implementation team. Next slide, please. Okay, so these are the main key lessons that I have, which are basically the lessons that we have learned as an organization. First, we are a doer at scale, but we also realize that we really can't really do everything all by ourselves. Hence, we therefore capacitate others as doers at scale, so that we work together. So just a few examples, we have Pangea Zimbabwe, which is basically an organization that works with peer-to-peer counselors. And basically, mainly their work is with regards to sexual reproductive health. And we collaborated with them, and we also helped them implement the Friendship Bench model right? And they are having an integration whereby they do provide sexual reproductive health lessons to people, but at the same time, they also provide mental health services. And we trained their peer counselors on how to support others in terms of mental health. Then we also have SESHA, which is just basically an abbreviation for Center for Sexual Health and HIV and AIDS research. They work with the LGBTQ plus community, and we also train them on how to provide or to give mental health support to their peers as well. So this is one of the key lessons that we have learned as an organization, that we basically can't do everything alone, but we can collaborate or capacitate others. And we have learned from them that, okay, in as much as we capacitate them with training, there's need for us to continuously supervise them, be it online and physical, and also to collaborate with them whenever they have their awareness raising as well. Then as an organization, again, we then realized that we then developed a toolbox, right? Which is the tool that we use as we scale, right, for fidelity. So this basically we refer to it as a friendship bench in a box scaling tool. Basically, what this box is all about, or what friendship bench in a box is all about, it's just basically a blueprint of what friendship bench does and the model that I've been talking around earlier. Then we have got mental health in the workplace, whereby we also try to spread mental health in the workplace, where we also realize that, you know what, in as much as people are going to work, in as much as people are employed, they might also be going through mental health, mental health conditions, or they're affected mentally. Hence, they need to create safe spaces in the workplace where they work. Can we move to the next slide, please? So basically, these are the key lessons that we drew as an organization. So I think this would be my last slide, whereby I'll share with you the recommendation or how best you can be intentional in addressing mental health in the areas that you work or in the organization that you work. So first, recommendation will be to identify the problem, right? Identify the problem within the community or within the context that you would want to implement. It's better that way because you know what you'll be addressing, right? And then there is need to, after identifying the problem, there is need to engage the locals or the target population. Like I mentioned here, as Friendship Bench, who identified the problem whereby the youth were being affected by depression, right? And as a result, we had to engage them, the youth as well as the locals, the grandmothers who were already providing the intervention, right? And be informed by your target population or the locals. Then again, it's always good to learn from your data, right? As you are doing the implementation or as you are providing sessions or as you are providing the service, please do learn from your data and be informed by that so that you implement or you scale up. Then collaborate with the government and tertiary institutions. Collaboration is very key because you really can't do anything all by yourself, but collaborate with whatever is in existence. Then lastly is to, as Friendship Bench, we realize that there's need to integrate the two, right? What really already existed and what was already there. That is, the grandmothers do work with the youth, as the youth will learn from the grandmothers. So basically, this is how I then, this is what I recommend that you do whenever you want to implement. Be intentional in addressing mental health. Thank you so much. I think this marks the end of my presentation.
Thank you so much, Mary, for giving us practical strategies to take away and a snapshot of Friendship Bench. So we're going to take the next 20 minutes to answer some questions. And so I'm going to open it up with the first question. And I'll ask both Mary and Nicola. So Mary, in your work with the Friendship Bench, have you found that there are different approaches to mental health for youth and adults, men and women?
Thank you so much for that question. So yes, we have identified that the approach actually tends to differ. And one way that maybe just to share with you, one way we have tried to address these issues is we have different people from different genders providing problem-solving therapy to these people or to these populations. So we, in as much as we talk about grandmothers, we also have grandfathers who do provide mental health, and we also have youths who are providing mental health services to others, to these other populations as well. So like I mentioned, we're learning from our data, and we realized that there's need to train males as well as youths in trying to accommodate everyone. I guess that they're answered.
Yes, thank you. And then Nicola, do you want to add anything to that question? Approaches for genders?
Yeah, that's a good question. And yes, we need to tailor approaches for different groups, demographic groups, men, women, young youth and young boys and young girls, or non-binary people. Why? Because the lived experiences are different. So the way they interact with the word and the word interacts with them will be different. Their needs will be different, and the types of stressors they face would be different. So definitely, yes.
Okay, thank you. And then the second question was for Mary, and it's asked, given the cultural context of Zimbabwe and the concept of kufungisisa that you mentioned, how does Friendship Bench navigate cultural sensitivities and traditional beliefs surrounding mental health to ensure effective acceptance of its intervention programs within communities?
Thank you for that question. So in trying really, when implementing, you realize like we really can't address all the cultural conflicts that do come around mental health. And like I mentioned, context-wise, acceptance of mental health is still very, very low, but we are trying. Maybe just to give an example, I mentioned the grandmothers. Here locally, you realize like a grandmother is someone everyone would go to if you have a challenge, be it the leader of the family. We talk of fathers, they consult grandmothers, right? Young people, they also consult grandmothers because they are regarded as people who are wise. So as for our approach, we started off with grandmothers because context-wise, these are the most respected people, and these are people that people can just go to whenever they need advice or whenever they need help with anything with regards to life issues. So yeah, basically, context-wise, I wouldn't say we really are addressing all the conflicts that do come with culture, but it's we're taking it step by step. And like I mentioned, some people are not really comfortable. It's a patriarchal society. Males mostly are not comfortable talking to a woman about their challenges that they're going through. Hence, us coming with males who also provide problem-solving therapy, who also normalize depression, that it's a mental health condition that everyone goes through. And so that we have that acceptance from males as well, who rather than having them being informed by grandmothers who are females. So we are trying our best to, go around cultural conflicts that might come around mental health.
Thank you for that. And then I want to see if, Mary, can you speak to the impact of Friendship Bench? I know it's been shown, it's evidence-based intervention based on your RCTs. So if you could give just some findings from Friendship Bench, outcomes that you've seen in the communities. And you're on mute.
Can you hear me now?
Yes.
Okay. So the impact that we have seen coming with this intervention, you realize like we realize that it really actually works. People haven't really been accepting what mental health is, but through the grandmothers, you realize that as an organization, they've done so well in providing mental health. And maybe just to share with you numbers for us to be able to, for you to be able to understand the impact that we have had. I think to date, we have reached close to 14,000 people, 727 people who have had sessions on Friendship Bench. just face-to-face counseling. And we have trained 200 to 245 grandmothers who do provide these, these sessions. And it has showed that 79% of the people have got a lower SSQ score. So basically, the SSQ is shown a symptom questionnaire that we use just to screen for depression, and you realize like there is a 79% reduction in terms of depression. So yeah, basically this is the impact that we have had when we have since we have started Friendship Bench.
Thank you. And really the uniqueness of Friendship Bench is that it's leveraging key influencers in the community. And so it's not like they're going to an outside a clinician or therapist. So it's going to be more widely accepted, reducing stigma. And so just thinking about ways that how can you use the community context to address mental health. You may have addressed this already with FB in the box, but there's a question on specific screening tools that you use for individuals interested in accessing the Friendship Bench platform. Like, can other people replicate the Friendship Bench? Is it open access?
Okay, so I'll try not to preempt on this one, but maybe people can use the link to our website where they can then get more information. So yeah, basically, Friendship Bench in a box is one scaling up tool that we're using for collaborations, as well as those who would want to replicate the model. And maybe just to share with you, in terms of context-wise, we realize that Friendship Bench can be replicated. I forgot to share this with you earlier. We are really now available in Malawi. You talk of Zanzibar, you talk of US, the New York City, we're also there. And yeah, those are some of the areas that we are in. And yet at the same time, we are using the same model here in Zimbabwe. So yes, Friendship Bench can be replicated in other areas as well, or in other contexts as well. So for those who would really maybe want to know more about how best they can go about it, you can access our website.
And also their speakers' emails will be in the presentation as well, so you can also directly approach them. You also spoke, Mary, about mental health in the workplace. And there's a question that says there's a willingness for workplaces to address mental health, but how can organizations break the stigma surrounding mental health and create a culture of openness and acceptance, especially in African contexts where mental health is highly stigmatized?
Okay, thank you so much. I think this is one of the challenges that we also have come across as an organization. Like, you realize that workplaces actually are not safe spaces for people just to, share about their mental health or discuss mental health issues. So what we have done as an organization is we have had a workplace initiative whereby we had different corporates coming through to the Friendship Bench, and we trained them on how to, provide support to each other. We basically trained our human resources managers. But then you also realize like people were not actually forthcoming to their HRs. And as a result, we then had people coming from the Friendship Bench, the organization. We have got internals that are trained. So we have grandmothers. We also have the Friendship Bench staff members going to workplaces just to provide that support. And for those corporates that we had trained, we also had we created exchange programs whereby we have got people who were trained from another corporate going to a different corporate. I'll give an example, maybe people coming from Friendship Bench, right? Going to maybe an organization like Pangia, because you realize like staff members within Pangia might not really be forthcoming to those who were trained, but rather they'll be forthcoming to have sessions or to have problem-solving sessions with those coming from Friendship Bench. Hence, we train corporates, right? But we then have them or engage them in having, exchange programs. Then again, we also hold community of best practices for these corporates so that they also share experiences on how best they are going around mental health awareness, as well as creating safe spaces within their corporates. Because like I mentioned earlier, as Friendship Bench, we really can't do everything, but having the corporates having a community of best practices among themselves and sharing experiences has been also quite helpful as well.
Oh, so that's wonderful to hear that you're doing a buddy system within corporations. There's a question that I saw here about compassion fatigue. Let me say, how does Friendship Bench approach put in measures to deal with compassion fatigue the buddies might experience during the sessions? And then I want to add something else as well, is how do you address any of the challenges that youth might have in implementing the program?
Thank you so much for that. So remember, I mentioned supervision and support, right? So we support them in the sessions that we have, but basically as an organization, you realize like Fridays, they are dedicated to, the mental wellness of the buddies. So we have different activities that they do conduct, whereby we just want them to just vent out or just to let the guard down. We know that after a week, they've been having different sessions with different people. So we have them have, be it lunch, they play ball games as well, just to support their mental well-being. But besides that, we do provide what we refer to as a monthly check-in for our buddies, whereby on monthly basis, we have our buddies have a session either with their supervisor or with the clinical team that is here at the Friendship Bench Hub, whereby they just share, be it not just basically about work, but we also understand that our buddies, they're also humans and they might also go through depression. So they have a session with the clinical team or with their supervisors where they just vent out either about life or about sessions that they have conducted. Then lastly, we conduct like the Friday mornings, they are just for like a roundtable session whereby one shares or they share about the most difficult case that they have come across. And we also try to address that challenge and how best they can go about it. And again, we share about the sessions that they feel good about, like they feel they have helped someone. They also share about the good work that they are doing. Basically, those are some of the things that we are doing. And then again, we also invite externals just to share with them on how best to go about different challenges. Remember, I mentioned we have the LGBTQ plus community. As Friendship Bench, we have managed to invite girls, which it basically stands for Gay and Lesbians Association in Zimbabwe. These, they do work with the LGBTQ community. So we invite them so that they also try to, educate our buddies on how best they can go about sessions and challenges that they might look forward to if they come across someone who belongs to that community. So basically, this is what we do as Friendship Bench to support our buddies' mental well-being as well.
Thank you for that. I'm going to open it up for the audience to talk about their work. I see in the chat, Nicolene said, we've integrated using existing traditional tools like fireside storytelling and group sharing with IDP programs and SRHR activities. Nicolene, if you want to feel free to expand more on that, or if any audience members want to take themselves off mute as well. Nicolene, thank you.
Hello.
Hello.
Chisina and everyone, thank you for this opportunity. Yes, just as I was saying, the storytelling and experience sharing is about when we come together, as I said earlier, work mostly with internally displaced women. They will share their stories of what is their experience during internal displacement. Maybe some were raped, some their husbands, some are widowed by the ongoing Anglophone crisis in Cameroon. I am from Cameroon, by the way, and I work with a small organization that is called Pathways for Women's Empowerment and Development and an Integrated Agricultural Training Center. So most of the women that we work with, they are victims of the ongoing Anglophone crisis. Some were raped, their family members were raped before them. Some have been widowed by the ongoing crisis. So they share their experiences of how they saw their husbands killed or their children or their loved one killed before them. And it is the tradition of our people that when we come together, when somebody is bereaved or in a stressful situation, when we come together, people will share their stories. Other people will also share how they lost loved ones, and for you to know that you are not alone in this situation. And then we try to, when they share the stories, we would like them to know what are the things that they think they can help them feel better This is something that you can never absolutely cure somebody from. So what do they think can help them feel better? Maybe most often they have lost their livelihood activities. They have lost the husband who was the principal breadwinner of the family. So we try to train them in adaptive income generating activities now that they are displaced in a different community, adaptive income generating activities, and we see how we can give them as small as it can be, startup capitals to keep them busy. You know, mental health issues are worst when you are idle, because when you are idle, the only thing that comes to your mind is the thing that caused you that mental health and that caused you to lose your livelihood. So we keep them busy. They go to the market, they buy from people who are coming from the villages, and they spend the whole day selling in the market. When they come back in the evening, they are exhausted. They can sleep and get up the following day, maybe forgetting about what is this thing that is killing them, is hurting them, is traumatizing them, and ruining their mental health. So that's how we do with the storytelling. And generally, according to our tradition, we light a big fire. If it is in the village in the evening, we light a big fire with firewood and we sit around it. We are roasting corn or plantains or potatoes or whatever is available. We are roasting and telling the stories. Other people who have been there before will tell you it will come to pass. I have been there before. When it happened to me, I thought I was never going to recover from it, but I have recovered. You too, you also recover. So these are just the traditional tools that are available to us. And that's why I was telling Nicola that I'll be very, very interested in getting some more training and some more strategies that can help us provide them with something more comprehensive and holistic. Thank you so very much.
No, thank you so much for sharing. I really love the fireside storytelling. It's basically similar to like talk therapy, but it's within a non-intimidating area. And you're right that when you're idle, you can increase rumination, like focusing on problems. So thank you. I also want to just acknowledge Melody, who said we're trying to bridge the awareness gap on mental health. Melody, do you want to talk a little bit more about what you were saying? I can read it as well.
Thank you so much, Justina. Yeah, I'm happy to share. So basically, I'm also working with Thrive Aid. It's quite a very startup organization. So it's in its formative stage as well. But what we're doing in the community really, and our focus is on the young people, is conducting some form of dialogue sessions with the young people. So we pick a topic, around mental health, and we have that our facilitators just open up the floor for young people to, share whatever experiences they have with the actual topic. From that platform, you understand that other young people who don't have that information get to actually become aware that there's actually this kind of thing is actually a mental health issue. So in Zambia, there's a very huge gap around awareness around mental health. So people don't even know what they're going through is a mental health issue sometimes. So that is the first thing that we're trying to bridge, just to make sure that young people are aware about that. And through that platform, as young people are sharing their stories, they not only get insights on what mental health is, but those who have faced similar challenges also gain the confidence to approach some of the psychosocial counselors that conduct the sessions afterwards to just have a one-on-one discussion. So what the group session does is it offers a support group kind of arrangement, but also it gives young people the comfort to open up to the psychosocial counselors who are conducting the sessions within the group sessions. So at least that gives them the kind of courage to walk up to those people after the session to just open up and have that one-on-one session. So that is just something that we're trying to do around awareness raising, and also increasing the access to mental health services, as there are very scarce mental health services in Zambia. I'll tell you that we only have one specialized mental health facility in the whole country. So we're just trying to bring those services within the community and within a context that is not intimidating, like a health facility or any other platform. Thank you.
Globally, there's a severe mental health access gap in access to services. So creating systems within the communities to address mental health concerns is so important. So thank you, Melody, for sharing that example. Nicola.
Yeah, I want to add to Nicolene and Melody's point one thing about the existing gap, which is a very important point. In previous jobs outside of YP2LE, what we try to do is train lay providers, so non-mental health professionals, on mental health approaches, and it was very, very important and it was very successful. What I mean to say is that results from the research and the assessment of post-treatment assessment with users of the treatment, and then a longer-term assessment on the effect of the treatment held up successfully. Basically, what we mean by that is that the symptoms of whether they came with depression, anxiety, behavioral problems, symptoms really went down. Just to note that we worked with adolescents and youth, Syrians, Lebanese, and mostly Syrians and Lebanese. And what we saw in one of the tools, of course, we had to, so when Mary talked about the adaptation phase and acceptability, we had to go through all of these to adapt the tools that we're using to be able to make them to be able to get community stakeholder input as well and adapt to the local context. One thing we noticed is that the correlation, they scored, if they had higher symptoms on trauma symptoms, the symptoms were lower if the feelings of community belongingness and support were higher. And this relates to Nicolene's point of the fireside chat as well, and the peer-to-peer chat that you were talking about. Sorry, that's what I wanted to say, Chisina. Thank you.
Oh, thank you so much. And, we really appreciate Mary and Nicola for sharing some of your work and recommendations. And we really hope that everyone can take one practical strategy and integrate it into the work. To close it off, I'm going to pass it off to Candice.
Thank you so much, Chisina. Thank you, Nicola and Mary, for your insights today. I think as myself as a gender activist, I learned a lot, especially around mental health. No matter what field you find yourself in, it's so important to include mental health in our programming, in our implementations, in anything that we do, because it is a part of us. So I think it's been very, very beneficial. And yeah, thank you to everyone who have engaged in the chat, for asking questions, for sharing their initiatives in terms of how they include mental health within their programming back home. So we just like to just reiterate again, if you would like to be a part of the Gender COP, please be sure to just join the link that we shared earlier. You can also feel free to follow us on social media. On Twitter, it's YP Learning. On Facebook, it's Youth Power Learning. On Twitter, it is Youth Lead Global. And on Instagram, it is Youth Lead Global. And if you would like some extra information from Nicola and Ziviko from Friendship Bench, please feel free to just email them. The email will be included in chat, especially if you'd like some extra information, if you want some resources. We will be sure to send the resources to the webinar, of this webinar, to you, to everyone that's been a part of it today. But I think that is it from all of us. If you'd like to know about any other upcoming YP2LE events, please just be sure to click on the links that Catherine has been sharing in chat.
Thank you, everyone. Enjoy the rest of your day and your evenings, and we will be in touch.